like we have discussed the infections previously, diphtheria and pertussis. Today, I will teach you about the tetanus. That was a very dreadful disease. Used to affect the both mothers and the neonates and the children, adults, everywhere. But there were occurring more of the tetanus, neonatal tetanus deaths previously, mostly in villages, and where unhygienic birth practices were done. But now, due to the awareness and availability of the tetanus injection during pregnancy, the vaccine, the incidence has reduced tremendously. So, like our general objectives will be like, say, the definition of the disease, then its etiology, etiopathogenesis, types, clinical features of different types, and then management, and then most important, the last is the prevention or control. So tetanus is also historically, it was called as lockjaw. It is acute sepsis paralytic illness caused by bacteria. Acute septic paralytic illness caused by bacteria. Which bacteria? That is Clostridium tetani. That is motile gram-positive spore-forming anaerobic found in human and animal feces, soil, and dust. So it's usually all the features are just opposite, which we have studied in the diphtheria, Corynebacterium diphtheria. So that was aerobic, this anaerobic. That was non-spore forming, it is spore forming. Okay, so that was non-motile, it is motile. So you can remember by this, and its main habitat is the human and animal feces, soil, and dust. So if it is present in soil and dust and human cow dung, so if it is applied on any wound, that is going to give rise to tetanus. Its epidemiology, used to occur worldwide, and it was endemic in more than 90 developing countries. It is endemic. Most common form is the neonatal tetanus. That is why we are teaching you in the pediatrics, because this was the most dreadful disease of the neonates. In India, in 1990, above 80,000 deaths from neonatal tetanus, but now decreased to 500 reported cases in 2015. So see that tremendous decrease from 80,000 to 500. That is the revolution due to the vaccination. So now India is certified as free of maternal and neonatal tetanus. Majority recent cases now in unimmunized children are more than 60 years of age. Etiology: neonatal tetanus in unimmunized mothers occurs in the neonates whose mothers are unimmunized during the pregnancy and before. Also, cord cutting is done with unsterile blades, then application of cow dung and soil. Or because of this, all unhygienic practices, neonates used to get this neonatal tetanus. And then second is the non-neonatal tetanus. That is due to the traumatic injury or infected or penetrating wounds or with unsterile injections. Then use of contaminated suture material. Then after intramuscular injection of quinines. And more common is after illicit drug injections. So animal bites, abscess, burns, compound fractures, frostbite, chronic skin ulcerations, gangrene, intestine surgery, ritual scarification, and female and male circumcisions. All these procedures, if there is contamination of the wound or unhygienic practices are done, then they are likely to get the non-neonatal tetanus. How does it press? What is the pathogenesis? Clostridium tetani is a non-invasive organism, and spore remains dormant in soil or contaminated tissue until a favorable condition of locally decreased oxygen reduction potential in devitalized tissue in presence of a foreign body. So this creates an anaerobic atmosphere, and these are the anaerobics. So whenever there is a reduced oxygen reduction in potential, they outgrow in number from the spores, they convert into the vegetative forms. So transmission of spores occur in a toxin producing vegetative forms. And these vegetative forms, they produce two types of toxins. First is the titanolysin and second is titanospasmin. First is the titanospasmin, is the main toxin, binds to neuromuscular junction at a site of injury, retrograde axonal transport, and reach presynaptic nerve terminal where prevents release of inhibitory neurotransmitters. Which are the inhibitory neurotransmitters? Which releases prevented, that is the glycine and GABA. Then it leading to uncontrolled contraction of muscles because they were the inhibiting enzymes, and their release is prevented. So there are now no inhibition for the contraction of the muscles. So uninhibited, uncontrolled contraction of muscles occur. The status toxins blocks the normal inhibition of antagonist muscles, or which in coordinated movement depend. So in consequences, affected muscles sustain maximal contractions and cannot relax. There is sustained contraction because of the lack of the inhibition of the antagonist muscles. And these are sustained spasm which do not relax. Then autonomic nervous system also becomes unstable in tetanus. Then hypo or hypertension, diaphoresis, then arrhythmias and forced defecation and high fever more than 40 degrees centigrade may occur. Then next is the Dhruv, please thoda dheere. Clinical manifestations. This may occur in various forms. That is the generalized tetanus and neonatal tetanus. These two forms are the most common. Third one is the localized tetanus, and fourth is the cephalic tetanus. First one I will teach you, generalized tetanus. This incubation period is 2 to 14 days or months. It depends on the distance between the site of injury from CNS. जितना CNS से साइट दूर होगा उतना ही लेट इन्फेक्शन होगा, उतना ही उसको ट्रैवल करने में नर्व्स के थ्रू टाइम लगेगा. Characteristically, there is a descending paralysis. Just it is opposite to Guillain-Barré. Guillain-Barré, you see the ascending paralysis. Here, the characteristic, there is a descending paralysis. Means first the face will be affected, and then the trunk and abdomen, and lastly the lower lips. It starts as trismus or lockjaw. So it starts from here. This temporomandibular joint is affected, and there is trismus, a pain in the opening of the mouth. So there occurs the lockjaw, and because of the lockjaw, the patient keeps in this like position. Like you will see that the patient is in the spasm of the facial muscle or is laughing. That is known as rhizus sardonicus or Then in the descending form, spasm of the neck, back, and abdominal muscles, and then the whole body. So when the whole body muscles are affected and the spasm occurs, then the patient takes a position like this, opisthotonus, like his abdomen and back is above, and both the lower limb and upper limb are at the on the ground. So like it is known as in the Hindi Dhanurasana, like a become shape of Dhanush. So that is the opisthotonus. Muscles show board-like rigidity. They become so rigid. Then laryngeal and respiratory muscles, airway obstruction and asphyxiation also occurs. Initially, spasm may last from few seconds to few minutes and then become sustained and exhausting. You see, in this child, you may see there is lockjaw. You can see the spasm of the muscles, rhizus sardonicus. Here also, there are no facial expressions. Then the neck is also tilted on one side due to the spasm of muscles. Then in the upper lip, there are the spasms. So this is the typical form where you can see the lockjaw, rhizus sardonicus, and some form of opisthotonus. Then, as disease progresses, minimum stimuli like light, sound, touch may trigger generalized spasm of tetanus, and it is the hallmark of disease and may cause death. जैसे एक छुई का पौधा होता है, उसको हम टच करते हैं, वैसे उसकी सारी पत्तियां सिकुड़ जाती है। तो अगर एक टिटनस का पेशेंट एक रूम में है और आप अंधेरा कमरे में रखा है, आपने जाके लाइट जलाई या थोड़ा सा भी वहां पे शोर हुआ आसपास, तो उसकी पूरी बॉडी में फिर से स्पाज्म में जाने लगती है, मसल्स उसको स्पाज्म आ जाते हैं। इसलिए the tetanus patient, when they are treated, they are kept in isolation at a very far place where there is no noise, no light comes, and no minimum, there are minimum stimuli. So he doesn't go into the frequent spasm. Then the toxin doesn't affect sensory nerves or cortical functions. So patient remains conscious in extreme pain, in fearful anticipation of the next tetanic spasm. पेशेंट इतना डरा हुआ रहता है उस स्पाज्म के कारण कि वो पूरे टाइम एंजाइटी में रहता है कि फिर मुझे नेक्स्ट स्पाज्म नहीं आ जाए, क्योंकि नेक्स्ट स्पाज्म के टाइम पर उसका पूरा बॉडी रिजिड हो जाता है, एंड ही हैज इन द एक्सट्रीम टॉक्सिन, it doesn't affect the sensory nerves or cortical function. तो cortical function को नहीं किया तो पेशेंट कॉन्शियस रहेगा, पेशेंट कॉन्शियस रहेगा तो he is aware of his spasm and conscious. So he is in extreme pain because the sensory nerves are also not damaged. There are sensations. So he feels pain, he feels anxiety because of the preserved cortical functions. Then tetanic paralysis usually becomes more severe in first week after onset, stabilizes in second week, then ameliorates gradually, and recovery begins after third week, and approximately it takes 4 weeks. Recovery from tetanus occurs by sprouting new nerve terminals in an spinal cord, leading to relaxation of contractile muscles. As you know, they affect the neuromuscular junctions, so they are damaged. So whenever the recovery, there is a regermination, you can say there is a regermination or sprouting of new nerve terminals, because the old are damaged, and once they are damaged, they cannot be repaired or they cannot be regenerated. Now, second form after generalized tetanus, most common is the Kittens Neonatal, about which we pediatricians are concerned mostly. It was a major cause of neonatal mortality rate in developing countries. No antibody transfer by unimmunized mother. Mother is unimmunized, she doesn't have any antibody, so they cannot be transferred to the baby. So baby is also unimmunized against the tetanus. Then second was caused the unhygienic birth practices like use of cow dung and soil and unsterile blades. Then symptoms usually appear on third day. It is never, that is underlined, it is never in first 2 days of life and rarely after 2 weeks of life. So any neonate coming with the spasm between third day of life to 14th day of life, it is more likely it may be the tetanus. But if the spasm are occurring before in the initial 2 days of life or after 2 weeks of life, they are less likely to be neonatal tetanus. Difficulty in feeding, hunger, excessive unexplained cry, because the child, because of the rhizosardinical lockjaw, he cannot suck the milk of breastfeeding, and he is hungry, and that is why he's crying excessively, and his unconsolable cry is there, unexplained cry. Parents don't understand that why he's not taking feeds and why he's crying continuously. And this is the decreased movements and paralysis, stiffness, rigidity of Tetanus, posturing with mouth slightly open, spasm of laryngeal and respiratory muscle result in the apnea and cyanosis. So initially the parents are not able to understand that why the child is crying and why he is not taking feeds. But as the spasm of the muscles start, or sometimes it may result into the cyanosis and apnea, and then they run towards the hospital. That they understand that something is serious. So high case fatality, that is the 70 to 100% if untreated in these cases. Now see the tetanus neonatal like this. Here there is lockjaw, rhizus sardonicus, spasm of the muscle. The child is not able to open the mouth. There contraction of the neck muscles also. Loss of the facial expressions. See. So this is the tetanus neonatal typical look. Third form is the localized tetanus. It is less severe. Painful spasm of muscle adjacent to wound site only may precede generalized tetanus. But if it is untreated, if it is the wound is not taken care of, then the infection may travel upwards or it may travel to the CNS system, and then it may cause the generalized tetanus. Mortality is less than 1%, because usually it is treated there only and it doesn't progress through tetanus. So mortality is also very less, and this is the most less dangerous form of the tetanus. Then this is the cephalic tetanus, is the fourth type, and this is the most dangerous type of the tetanus that occurs due to the injury to the bulbar muscles due to wound or foreign body in the head, nostril, face, or otitis media. Usually it occurs in the road traffic accidents. Are usually if there is a wound in the head or nostrils or face, and directly there is a foreign body enters and it affects the bulbar muscles. It is characterized by retracted eyelids, deviated gaze, trismus, rhizus sardonicus, spastic paralysis of tongue and pharyngeal muscles, and poor prognosis. Diagnosis typically history, immunization, home delivery, injury within preceding 2 weeks. Then nothing significant into other tests. CBC, there may be leukocytosis, which is very non-specific. CSF pressure only may be raised, otherwise it is normal. Gram staining, Clostridium may be visible in only 1/3 cases. So nothing is confirmatory. Only the history and clinical features that you may have strong suspicion and you have to treat. So once again, I will revise you the typical features of tetanus. You see this intact sensorium, how anxious he is looking in the anticipation of the next spasm, because the cortical functions are intact. Then he may have headache, difficult swallowing because of the dysphagia, sore throat, irritability, tonic spasms, and prevention of childhood immunization is the prevention. He is having spasm of facial muscles, then jaw stiffness, fever, restlessness, chills, exaggerated reflexes, and profuse sweating. So differential diagnosis. So any other spasm can they be confused? I told first about the incubation period. If they are before 2 days of life and after 2 weeks of life, and there is no history of home delivery or like unhygienic practices, they are less likely to be neonatal tetanus. So trismus or differential diagnosis, trismus also occur. You may confuse due to different symptoms like trismus lockjaw. It may occur into parapharyngeal or retropharyngeal or dental abscesses also. So you have to differentiate between this, but you will get a typical history. Then rarely encephalitis, which involves the brain stem. Then you may confuse with the encephalitis. Then animal bites, like you may confuse with the rabies, but rabies hydrophobia is the hallmark, while the spasm due to the minimum stimuli are the hallmark of the tetanus. Then generalized seizures, you may confuse with strychnic poisoning, epileptic seizures, narcotic withdrawal, and other drug interactions. Then spasm may be hypocalcemic tetany also. So you have to differentiate between that. Now, what is the treatment? Intensive care management. Whenever you have a diagnosing, you have to diagnose and you have strong suspicion, you have to treat the patient into the intensive care. The second is endotracheal intubation if frequent laryngeal spasm and apneic attacks are there. And if endotracheal intubation is not possible, then you have to perform immediately tracheostomy. Then surgical wound excision and debridement. Then tetanus immunoglobulin. Neutralization of free toxin by administration of human tetanus immunoglobulin TIG. Dose is 50 to 1000 units intramuscular or intrathecal. If TIG is not available, then give either human intravenous immunoglobulin or bovine derived tetanus antitoxin, that is TAT. Dose is 50,000 to 1 lakh unit, half given IV and half intramuscular. But nowadays it is obsolete, or it is not, because of the, it used to cause serum sickness. So we use the TIG. But if you have strong suspicion and TIG is not available and TAT is available, then to save the life of the patient, you have to give TAT also. Now, second, the TIG is the mainstay of the treatment. Second is the antibiotics. What antibiotics you will give? First choice is the penicillin G, 1 lakh units per kg per day, every 4 to 6 hourly, intravenous 10 to 14 days. Then alternative is the erythromycin, tetracycline in more than 8 years. Then metronidazole is 500 milligram intravascularly 8 hours in adults. As you know, they are the anaerobic infections, and metronidazole helps him to kill them. Then for the spasm, you have to give spasmolytics like muscle relaxants. What that is? Diazepam in the 0.1 to 0.2 milligram per kg every 3 to 6 hourly intravenously, bolus or continuously IV infusion for 2 to 6 weeks, and then taper it. Then pancuronium bromide or vancuronium can be used for the severe spasm. After this, alpha and beta adrenergic blockers to control the autonomic instability. Then tetanus toxoid, that is TT, complete course of primary and booster to all the patients, as it does not provide the active immunity. The TIG is going to provide you passive immunity. Now, what is the supportive care of the patient? Admission to delayed, quite secluded setting to avoid noxious stimuli, endotracheal intubation or tracheostomy, frequent suctioning, cardiorespiratory monitoring, then maintenance of substantial fluid, electrolyte and calorie need, and good nurturing care of mouth, skin, bowel, and bladder. Complications are aspiration of secretions and pneumonia. Then prolonged ventilation causes pneumothorax and mediastinal emphysema. So you have to take care of that also. Location of, then laceration of mouth and tongue may be there. So you have to prevent the tongue bites also during the spasm. Then intramuscular hematomas, rhabdomyolysis and myoglobinuria, renal failure, fracture of long bones and spines, venous thrombosis, pulmonary embolism, gastric ulcers and paralytic ileus, iatrogenic apnea, cardiac arrhythmias, asystolic, unstable BP, and labile temperatures. Prognosis is the disease has a high mortality rate in spite of good supportive care. It may reach up to 50% in severe generalized tetanus. Now 90% there may be in neonatal tetanus, 95 to 100% in cephalic tetanus because of the respiratory and feeding difficulties. So the prognosis of neonatal tetanus is worse if onset of symptoms is within first week of life. If it is late, then prognosis may be good. Then interval between the trismus and spasm is less than 40 hours. It means that due to the interval between the first symptom and the last symptom is less, then the disease is progressing fast. So prognosis will be poor. But if the spasm is more than 48 hours, the prognosis is good. High fever and tachycardia, laryngeal spasm leading to apnea. Now, as all of these infections, the prevention is the most important part. Tetanus is an early preventable disease. Maternal immunization, 2 doses of tetanus toxoid, preferably between 27 to 30 weeks of pregnancy. They prevent both maternal and neonatal tetanus because the mother develops antibody and it are transferred to the neonates. Then serum antibody titer of more than 0.01 international unit per ml is protective. So you can see by this titer also that if the titer is there, means the person is the protective against tetanus if you don't know the status. Then active immunization, 3 doses of DPT, that is 6, 10 and 14 weeks of age, and 1 booster dose at the age of 18 months and second booster dose at the 5 years of age. And then TD, that is the capital and small d at 10 years, and then even every 10 years, it interval throughout the life, it will protect you against the tetanus. Unimmunized children more than 7 years, if it is coming to you, then 3 doses of TD. Instead of DPT, you have to give 3 doses of TD toxoid, given intramuscularly, with second dose at 4 to 6 weeks after first dose, and third given after 6 to 12 months after the second dose. And wound management in this also is very important. Tetanus prophylaxis is an essential part of all wound management, and animal bites, thorough surgical cleaning, and wound debridement should be done. Okay. Good morning. So now today I will teach you about a condition, juvenile idiopathic arthritis. What is juvenile? Juvenile is a childhood or till adolescent period. Idiopathic means the etiology is not known. And what is arthritis, that I will explain you initially, and then we will go about to study about the juvenile idiopathic arthritis. So, Neki, please thoda sa dheere wo. Specific learning objects are definition of arthritis and its classification, then definition of GIA and its subtypes, then incidences and etiopathogenesis, clinical subtypes, then we will learn about the diagnosis, differential diagnosis, and lastly the treatment. So what is arthritis? It is a common complaint in children. It is a is to be present if there is a swelling or infusion in a joint, or any two of the following features are present. So when you will tell that it is a arthritis, there should be either swelling or infusion of a joint. So, and there should be any two of the following features are present. Number one is limitation of range of motion of that joint. Second, there should be pain. Third, there should be tenderness. Fourth is the increased heat. If any out of this four, any two things are present, you can call it arthritis. And it may be either a primary disease itself, or secondary to an underlying illness like infection or non-infection, like infective arthritis also. So classification of arthritis, it is depending upon the duration. Acute arthritis, subacute arthritis, and chronic arthritis. What is acute arthritis? Usually less than 2 weeks. Like it occurs in acute rheumatic fever, transient toxic synovitis, then henoch-Nolan purpura, Kawasaki disease, septic arthritis, that is the Staph aureus, H. influenza, and Neisseria meningitis secondary to this bacterial infections. Second is subacute arthritis. Usually it is between 2 to 6 weeks. And it is reactive arthritis, SLE or dermatomyositis, or it may be polyarthritis nodosa, like all these autoimmune type of arthritis are subacute. Then sickle cell disease, that is a type of hemolytic anemia associated with leukemia or neuroblastoma malignancies, associated with Lyme disease or brucellosis, and associated with hypogranuloglobulinemia. Then chronic arthritis. If the arthritis is present more than 6 weeks, then it is known as chronic arthritis. It may be present in juvenile idiopathic arthritis, which we are going to learn now. So now you know that if there is chronic arthritis, then you have to keep in mind juvenile idiopathic arthritis, ankylosing spondylitis, tubercular arthritis, psoriasis, or Lack-Cow-Pertz disease. So juvenile idiopathic arthritis, or it is also known as first juvenile rheumatoid arthritis, known initially. GI is a latest term given by pediatric standing committee of International League of Association for Rheumatology, that is known as the ILAR. Its definition is arthritis of one or more joints. Please, thoda sa dheere. Definition: arthritis is one or major joints which onset below 16 years of age and persisting for at least 6 weeks. It has the following subtypes. You know that is a chronic type of arthritis, so it is persisting more than 6 weeks. And what are its subtypes? Number one is systemic JIA. Second is oligo arthritis, in which only mainly one joint is involved. That may be a persistent or extended. Again, it is divided into two types. Then third is the polyarthritis, in which more than one joints are involved, in which they are again of two types. RA factor may be positive or RA factor may be negative. That is known as seronegative arthritis. Then psoriatic arthritis. This may be associated with the psoriasis. And then lastly, enteritis-related arthritis. Enthesitis-related arthritis, and undifferentiated arthritis, that is the fits known not another any category, or it fits in more than one category. Then we give this arthritis into this category. Its incidence is prevalent in 1 into 1,000. It is not very common, but has potential for disability and long-term morbidity if not treated in early time. So this is very alarming situation. It becomes very alarming for the parents and for the child himself. So that is why it is it should be diagnosed early. In India, female predominance is not marked as it is in the Western countries. Females suffer more than the males. Now its etiopathogenesis, etiology is unknown. That is why this is known as idiopathic. There is the markedly distinct pathogenesis of oligo, polyarticular, and GIA and systemic GIA. Then the former is thought to be an autoimmune disease, which leads to failure of T cells tolerance to self antigens, which contribute to synovial inflammation of the oligo or polyarticular joint. Then several environmental triggers like some viruses and tuberculosis mycoplasma and anticoagnism, or physical trauma or psychosocial stress may be linked to this. Then third hypothesis, the classical IgM Rh factor is almost never detectable in the preschool children with JIA, so also not supportive. Clinical features: three major types of onsets are described according to the presentation of disease during first 6 months of the disease. And you can say this is the clinical subtypes. First is the systemic JIA, that is the fever and rash. Second, oligoarthritis, that is 4 or fewer joints involved. Third is the polyarthritis, more than 4 joints are involved. So oligo means less than 4. Poly means more than 4. So first I will teach you about the systemic GIA. Incidence is about 5 to 15%. It can occur at any age and more common in boys. Then the systemic features and fever may precede the joint manifestation by weeks or months. So it should be taken into differential diagnosis of a child coming with prolonged fever. You should always keep in the DD-GIA, systemic GIA. Usually begins with child may not be having joint pain that time, but then he may develop later on. It usually begins as an intermittent fever, usually more than 39 degrees. It characteristics twice a day peak for more than 2 weeks. So this is the characteristic fever. And fever is a prominent in the evening. It is generally accompanied by a maculopapular rash. Marked irritability is there. Then serosal involvement in form of pericardial or pericarditis or pleuritis. So the serosal membranes are also involved. Prominent hepatosplenomegaly may be there, and lymphadenopathy may be there. Now, oligoarthritis, that is known as polyarticular disease. Why poshy? Because it is less than 4. Incidence is most common. It is most common type. Approximately 60 to 70% of GI patients are having oligoarthritis, of more common in young girls, that is 3 to 5 years of age. Then 4 or fewer joints, usually large joints of lower limb, except hip joint, are affected during first 6 months of disease. Joint swelling is more than joint pain, and hip joint involvement is never a presenting sign of JIA, but it can occur later. So this is the last possibility. If hip joint involvement is there, it is the last possibility, because it is usually this involvement is very rare, and if at all it occurs at the very, very late stage of the disease. Then two subtypes are persistent and extended. What is persistent? If number of affected joints continue to be 4 or less. Extended if number of affected joints exceed 4 during course. So it comes into the polyarticular, it extends into the polyarticular disease. The asymmetrical involvement of knee or ankle is characteristic. Asymmetrical involvement of knee or ankle. Then small joints of hands and feet are not involved. They are usually free. Asymptomatic blinding. Then iridocyclitis can be seen in 25% of the patient, especially in girls with ANA positivity. So eye involvement may be there. There can be blindness also. Now polyarthritis. Incidents occur in 25 to 30% of the patient. More common in girls. Involvement of both the large and small joints of both upper limb and lower limb. As many as 20 to 40 joints may be affected in more seriously involved child. Joint pain is out of proportion to the degree of joint swelling. Fever and malaise can be significant. Two subtypes are common. First is RA factor positive and second is RA factor negative. What is RA factor negative? It can occur at any age in childhood. The disease is far or less severe than RA positive patients. Then knee, wrist, and hip joints are usually affected, and small joints of hand and fever are less commonly affected. Then RA factor positive. Then age onset is late in childhood and early adolescence, and arthritis symmetric, and it is additive, severe, and there is maybe deformative involvement. Small joints of hands and especially metapharyngeals and proximal interpharyngeal joints are there. So it is opposite of the oligo articular joint involvement. Here, small joints are involved. Then cervical spines, and then this temporomandibular joints can also be affected. Then this RH nodules are present in some patients and usually indicate severe disease. So now the diagnosis, there is no pathognomic features or lab test for confirmation of disease. You know, this etiologenesis is not known. It is idiopathic, and that is why there is no confirmatory test. Characteristic history and examination are only useful tools. Then supportive lab tests like CBC, it may show moderate neutrophilic leukocytosis, thrombocytosis, anemia of chronic disease, increased ESR and CRP. Then synovial fluid microscopic and culture may be helpful to differentiate septic arthritis. Then bone marrow aspiration for differential diagnosis of all. Then X-ray of affected joint at the time of initial diagnosis and may be repeated for a assessment of the erosive disease. Then a RA factor, not useful but important prognostic factor in situation where it is positive. Differential diagnosis: acute rheumatic fever, Lyme disease, psoriatic arthritis, septic arthritis, acute lymphoblastic leukemia, and all other causes of arthritis. Treatment should be multidisciplinary, as medical therapy, physiotherapy for relieving the pain, then maintenance of posture and joint mobility, improves muscle strength and prevent fixed flexion deformities. This is all done by physiotherapy. So this is the mainstay of the therapy. Then occupational therapy and ophthalmologic checkup and follow-up if there is eye involvement. Then medical therapy, non-steroidal anti-inflammatory agents are mainstay of symptomatic management. Commonly used drugs are naproxen, that is 50 to 20 milligram per kg per day, BD maximum 75 milligram per day. Second is the ibuprofen, 30 to 55 to 40 milligram per kg per day, and OD, and it maximum is 2400 milligram per day. Third is the indomethacin in the dose of 1 to 2 milligram per kg per day, TDS, maximum 15 milligram per day. Then next is the diclofenac, 2 to 3 milligram per kg per day, QID, maximum 150 milligram per day. And last is the piroxicam into 0.3 to 0.6 milligram per kg per day, OD, maximum 20 milligram per day. Most children with oligo arthritis respond to non-steroidal anti-inflammatory agents, but most children with polyarthritis or systemic JIA will require additional anti-inflammatory drugs or disease-modifying anti-rheumatic drugs that are known as DMARDs. An approach to use the combination therapy to beginning with the least toxic manifestation, proceeding through the methotrexate and or infliximab. Then we progress to the more toxic drugs. Then like azathioprine, then TNF blockers, and like then intra-articular injections of glucocorticosteroids. So these are the progressive treatment which increase in the term of toxicity. So first we should use with the methotrexate, which is less toxic. Prognosis: every child has unpredictable prognosis. Oligo or polyarthritis with RA factor negative generally have a good prognosis. Children, especially girls less than 6 years of age, are at a risk of developing chronic uveitis. So this eye involvement is more in girls, and systemic GIA patients are most difficult to control. And marked systemic disease is usually present only during the first few years after onset, and then tends to regress over time. It may have complications like spondylitis, then sacroiliitis, localized deformities, flexion contractures of hips, knees, elbows, result in permanent disabilities, neck stiffness, then temporomandibular joint involvement or growth disturbances, limb length discrepancies, and systemic GIA patients may develop macrophages activation syndrome, where intravenous methylprednisolone can be life-saving. So what this, thank you for the patient listening, and this all about the JIA. So now you must have